Welcome to the wonderful world of wellness with Dr. Andy Mencia. This medical program heard from 7 to 7:30 each Saturday right here on WSBR 740 AM is brought to you by the Adult and Geriatric Center under the medical direction of geriatrician Dr. Andy Mencia.
Well, good morning.
Good morning. Do you know this is the first Saturday in June?
I'm still sleeping.
No, you're not.
No,
You're
just
never.
kidding.
I don't even know if you sleep. The first Saturday in June.
Yes,
So it's June the 4th.
June the 4th, and we already have 3 tropical depressions.
Oh, yeah.
Yeah, the third one is going on. It's like, what's going on here?
Well, I'm
but
not
it's
depressed.
better for them to come.
I'm not depressed, are you?
No. That's why we are the antidote to tropical depressions.
That's right. We're not
They
doing
say, bring Andy and Anita on.
Yes, but you know, one thing you always do, you bring the most attractive people here. Beautiful Ina.
Ina, say good morning. Dobre утро.
Доброе утро.
And
Хорошо.
Очень хорошо.
That's it. That's my Russian.
oh, okay, that's it. And we have such an attractive gentleman here. That's why we're going to get on television very
Yes,
soon, right?
yes,
So
yes.
people can see, our
and
wonderful.
they can learn from somebody like Dr. Ayala, because you're going to hear about his background
Yes.
and what he's actually doing now. That I felt like, wow, this guy deserves a whole hour.
But we're only going to give him a half an hour with you, right?
Yeah.
I know we're going to give him an hour, but you're going to tell us a lot of things. But it's Dr. Ivan L. Ayala, and Dr. Ayala is actually a cardiologist, isn't he?
He's a cardiologist.
Why don't
Good
you
morning,
tell us-
Dr. Ayala.
Good morning, Dr. Ayala.
Good morning. First of all, thank you for inviting me. I'm already enjoying this. It's my first time, so you got to bear with me for being a rookie on radio.
Well, no, when you think about it, when someone goes into the hospital and you have to take care of them, it's their first time too.
Correct.
And so it does take someone being nice to someone, having fun, and we know what bedside manner is, whether you're a cardiologist or you're an internist or you're a brain
Or a
surgeon.
radio host.
A radio
right?
host, that's right. Because
So we
people
make you
are-
feel comfortable.
Yeah. Do you feel comfortable?
Absolutely.
That's the end of it. Now you got to get down to business. So tell us what makes you so famous.
I don't think I got there yet, but no. Actually, I'm a cardiologist that I was trained as a regular clinical cardiologist, but also an interventionalist. And I did my training in Chicago and at St. Francis Hospital, affiliated with the University of Loyola many years ago. And then I moved to practice here in the beautiful South Florida. However, after doing interventional for a few years...
Wait, excuse me. Tell people what that means, interventional, please.
Interventional is a cardiologist that does cardiac catheterizations. That's something that people probably know more of. What you do is you puncture one of the arteries in usually the legs and put catheters and that reach all the way to the heart, and you inject dye around the coronaries in order to be able to visualize the coronaries and find out if you have blockages or not, and then if something needs to be done. Once you determine that there's a blockage, we put a balloon or a stent these days and fix the problem. So that's a very big field, and there's a lot of people that need this, and there's a lot of interventional cardiologists.
I was talking to one of my patients. He's in the 90s, and he's a retired cardiologist, of course. And we were talking about, you and what you are doing now, and that you are an interventional cardiologist. And, I was so excited what you are doing at the moment that we're gonna talk about. And he said, Dr. Mencia, people don't even appreciate what interventional cardiologists took us away from. Because he said before, somebody will come in with chest pain. And the only way you can tell the person, if you say to the doctor, I want to know with certainty if I have a heart condition or this is reflux, they will break your chest open. They will open you, look at the heart, look at those blood vessels, and that's how people were being evaluated. And then the interventional cardiologist came along and they will go through one of the circulatory system
An
that we
artery
have,
that goes up
go
there?
through and go into the heart, and we'll be able with that without open your chest open to say your heart look healthy or no, because you will look at all the piping,
All the coronaries.
all the piping that go in there to bring blood and to take blood away.
Exactly.
He was a plumber.
I was a plumber,
You know,
yeah.
the one thing about Dr. Mencia, and you're going to find whether he finishes and he does on the show or not, but he takes...
I break it down.
Yes, he does. He breaks it down. That's what's so nice. He can take something so simple and he puts apples and oranges with something, which is really the way, because so many people go to a doctor when they get finished. They have no idea what's wrong with them or what the doctor said.
Well, what we do not do as cardiologists is to do the whole system, and Dr. Mencia takes care of the whole person. And that's the value of having somebody with the general knowledge that they can take care of the whole person, because the heart is just part of the whole system, and sometimes the whole system has to be in good shape in order for the heart to work properly.
Right.
So it's very important to have somebody that's managing the entire patient and not just one part, as we generally tend to do sometimes.
But it's interesting for both of you to hear this, that when it seems that when someone has a problem with their heart, and whether they've had surgery or something, they never seem to be the same. It seems like they always think they're going to, they don't want to have sex, they don't want to do anything, they're afraid that they're going to die. So maybe you can address that, Dr. Ayala. I know it's not on your list of questions, but we always have to...
No, that's an incredibly important question, and the way it goes is this. Unfortunately, the heart is something that cannot wait. You have some pain in your shoulder, and you can have an impingement and whatever, or even an upset stomach that is just bothering you, and that usually is not going to kill you. It may, if it's something very bad, but it may not put you in the position mentally that you're going to die in the next minute or 2 days or whatever. But when you end up having a heart problem, it's something that could go bad in no time. Some people, unfortunately, pass away, suddenly. That's one of the things that we're going to discuss, that we have gotten to be so good at treating patients with heart problems once we diagnose them. But the problem is our incidence of sudden cardiac death, that means people dying suddenly, has improved very little over the last 20 years. And that is because we're not achieving prevention. We're not getting the prevention to everybody that needs it. And that's going to be one of the topics I'm going to go forward in here as talking about prevention and calcium score in the next few minutes.
Okay, so let's go for prevention. That's what we want.
So if a person comes in, Dr. Ayala, and they want to, because we do a lot of preventive care at the office. A patient come in, and now we're talking about cardiovascular CT scan, which is one of your expertise. Why don't we educate the listeners on what is a cardiovascular CT scan?
Okay, great. When I was talking about my background, I was a cardiologist, interventionalist, but along the way, I felt that in order to keep practicing medicine and loving it, I needed to move on. And imaging came in, and I fell in love with it, and that's why my area of expertise is now imaging, and in particularly more dedicated to CT scan. I'm also do cardiac MRI, and as well as of course ultrasound and nuclear cardiology. That's the regular stress test, thallium stress test that people know it more by. But going back to CT scan for the heart, it's something that was born, specifically calcium score, and I'm going to explain what calcium score is. It was born in the early 1990s. Some people remember the ultra-fast CT was called at that time. Right. It was made by Imatron. That was the scanner. It was an electric beam that was generated. It went through your body and imaged the heart for the first time. Those were the first images of the heart. So people got very excited. And what those images showed is calcium deposits in the coronaries. Years after that, we've discovered that there were people with some of the mummies in Egypt that they did some CT scans. They end up at a young age already having some calcium deposits. So this is an illness that's been with us for hundreds and hundreds of years. So the way it was born, it was with that kind of CT. And since then, we have had thousands of papers written about calcium score. What calcium is in the coronaries is the trademark of you got the disease. You have atherosclerosis. Nothing is going to be more certain than that, than telling you, okay, you know what? I have started the disease. You may be 70 years of age, and sometimes I do this scan in people, and they don't have 1 iota of calcium. Very few of them, but that could be the case also. Not necessarily everybody develops it. But when you have it, you have the disease. And if you have it at an earlier age, your risk increases because you already started the process very early on. So calcium score is an incredibly useful test in order to determine if you have the disease or not. You may have many risk factors, hypertension, diabetes, high cholesterol, and they come to your office.
Family history of early heart disease.
Especially if you have if you have early family history, family history of disease, then what happens is that most of our parameters, the Framingham score and the ways that we evaluate patients' risk, they don't consider family history of heart disease, which is something that
basic.
So basic,
yeah.
And we're finding out more that has a lot more value than we thought it did many years ago. So if we consider somebody that has all those risk factors, and we say, according to our guidelines, now I'm going to talk, if I may, for a couple minutes about the guidelines. Years ago, our guidelines were that once you have a high cholesterol, you have to be treated, and you probably remember, Dr. Mencia, cholesterol, LDL, that's the bad cholesterol, to drop it below 120, 100. And sometimes when people had the disease, we were pressured to lower it less than 70 in order to reduce the risk in those patients. But the latest guidelines in 2013 got away from that simply because it was felt that there was not enough evidence that doing that was really going to be accomplishing what we wanted to.
So there were people taking statins for that, weren't they? And
Absolutely.
And that was not a good thing.
Well, it was not a good thing doing and going by the numbers that say, it got to drop over down below 100 or 70. So those parameters were eliminated with the new guidelines. And the new guidelines say basically that if you have the risk between 7.5 and more than 7.5 per year, all the way up to 20 per year, then your risk is high enough that you need to take the statins. Those are the parameters. The problem with the risk calculator, you can find this on the website. The risk calculator, basically you enter your age, your sex, if you smoke, how's your cholesterol, and it drops you a number. And if your number happens to be between 7.5, over 7.5, then your risk is high enough that they say you need to be taking statins.
Well, wait, I'm going to keep stopping you because I know my listening audience needs some information on this. Does that mean then that you're clogged veins? What's clogged? The arteries? When you say it's high, what's happening inside your body? Right.
The problem is just compare this to a puzzle. Right now, the patient comes and says has high blood pressure, diabetes, high cholesterol. If you do measure your risk with this risk calculator, it's going to come out, let's say, at 10. That's 10% risk 10% risk per year that you can have major cardiovascular events.
Ah, okay.
Right. So the number that you get, the higher it is, the higher the risk of having an event.
That's an event.
Now, you didn't talk about the good cholesterol. What about the ratio? Because we spoke about what the bad cholesterol and where we want the bad cholesterol to be. What about the HDL, the good cholesterol, and what role does it play in today's calculations?
Good question. Right.
That's a key issue because the HDL is our good cholesterol, and we are genetically determined sometimes to have lower values, which increases our risk of heart attacks. So it's a complex scenario because on one hand you have the bad cholesterol that if it's high, your risk is higher. If your HDL, which is the protector, is lower, you also fall in the category of risk. That's why in these risk calculators they ask you what your HDL is, because if your HDL is low, boom, your risk goes higher. Then you need to take statins.
Oh, because
okay, let me translate it in Russian.
But I want to ask you, no, not in Russian, because I've had that said to me years ago that this may be high, but the other balances it out, and so it's okay. So they're balancing one with the other.
Right. But let me translate it in Russian. So if you live in a community and you have 20 thieves and 5 policemen, the chances of you being protected if you move into that community are very low,
good.
very low of you being protected.
Right.
Now, in the same community, you have 20 thieves, but you have 200,000 policemen. You are much better protected.
Oh, yeah.
So
I want to live in that community.
the HDL are the cops, and the LDL are the thieves.
Oh.
So if you raise the HDL, then you're going to be protected. Now, you have to be careful because that's where Dr. Ayala work in harmony with each other, because before I was educated on what HDL and how do you get good HDL, I would tell my patient, just go and buy some fish oil. And people will go and buy fish oil and will look at the level. And sometimes the bad cholesterol was going higher and the good one wasn't moving at all. I said, oh my God, what the heck is going on here? This is not right. So I started doing research because I had a patient with multiple sclerosis where the HDL is extremely important to have it at a very high level. So I started doing my research and I found out, there are 3 types of fish oil. You have the omega-3, the omega-6, and the omega-9. But the only good one are the 9 and the 3. The 6 is bad fish oil. So we will get omega-6, let's say, from ice cream, from a hamburger, from French fry. That's where we'll get omega-6. And then people will sell quote-unquote fish oil that will be loaded with omega-6 and not 3 and 9. So then I started doing more research. I say, where are the good fish oil and who's making them? And that's how I started selling product in my office, because it was so hard to explain to the patient, don't buy this kind and buy this brand. I say, if I have the brand, I say, well, you have it here. You can buy it from the street because, you can do whatever you want to, but at least you are educated on what
and
is
people
successful.
didn't know that. They thought they get omega oil and it was all perfect, and you found that out.
Yeah.
So you're saying that you get the 3 and you get the 9. I didn't even know there was a 9. I always thought there was a 3 and a 6. There's a 9.
Right.
Okay.
3, 6, and 9. There are three type of fish oil.
By the way, when I come to your office, I do have to have some more D.
Vitamin D.
I ran out of D.
Mm-hmm.
Okay.
So going back, Dr. Ayala. So we bring up the good cholesterol, and so the person is more protected. But let's go to the cardiovascular CT scan and the calcium scoring. Ina, that is 16 years old, come to me and has a 16 or 17, or 21. 18. She just turned 18. Oh, my God.
You now drive.
Yeah. I don't know, doing Botox on these 18-year-old girls. I don't know if I'm doing the right thing, but we'll continue.
But she doesn't look like she has it. But you can't even tell. There's no heart problem there.
The 2 things that come up, when people are sitting at home listening to us, do I have to do this through my insurance? Can I do this incognito? If I want to do it through the insurance because I cannot afford the test, would the insurance pay for this test for me?
Okay, that's a big question, and definitely I'm going to answer the best that I can. And before I do that, I'm going to clarify a little bit about calcium score. Calcium score is something, like I mentioned, extremely important in diagnosing if you have the disease or not. With the cholesterol guidelines, and the intention was good, to reach more people that can take statins, so we will reduce the risk in more people. Unfortunately, that is being done at the expense of people taking statins that they don't really need it. I mean, let me explain you why. There's a recent study that was done. It's called the MESA trial, MESA. It's been done. It was done. It's a longitudinal study, observational study that they took thousands. I think it's about nearly 6,000 people, and they with all the risk factors, and they also gave them a calcium score to each one of them, and see how they would develop cardiovascular illnesses, myocardial infarctions, or even dying over the years. And this doctor from Miami, I think his last name is Nazir, published just recently in the last few months in the American College of Cardiology study, in which by applying the latest cholesterol guidelines to that population between ages 45 and 75, it was found out that 75% of those people qualify for statins. According to the guidelines, then we would be treating 75% of that population, which is alarmingly high. I mean, basically, you're left with very few people not being treated.
Not being treated.
And that was the criticism early on of the risk calculator used for the new cholesterol guidelines, to be overestimating the risk. So what this gentleman did in a very nice way, he took the people that were candidates for statins and saw what was their calcium score in that population. So basically, it came out with the numbers like this: like 50% of those people had calcium score of 0, had no disease. Mm-hmm. So for the first time, the biggest question came is, what am I doing by treating these people that have 0 calcium? All of a sudden, with the risk calculator, which saying that this patient has at least a moderate risk, with a calcium score, the category drops down to low risk. And in the low risk, taking statin doesn't help. Your risk is so low of dying or having an MI that statins are not going to help.
It's an overkill.
Exactly. So what the intention was good, but at the expense of having people taking medications when they don't really need it.
And that was a fantastic discovery.
Yes.
That was a fantastic discovery. That is
an incredible paper that's going to be changing a lot of thinking in a lot of populations, because you want to stick to the guidelines. You want to be somebody that works with American colleges, with American Heart, and trying to promote wellness and cardiovascular wellness in all the people that you know of, that you treat. But this way it feels, at least to me, and a lot of people that are reading the paper, or people that wrote the paper, that it is going a little bit overboard by treating too many people in order to get our desired effect.
So, Dr. Mencia, the calcium score now, you're going to want to know about that with your patients, aren't you?
Absolutely. Yes, absolutely. And I guess we can bring that up after the break. But, one of the questions then come also is, before we used to look at the LDL and call all LDL bad cholesterol. But now they break down the LDL into the particles size. And in that study that you mentioned, Dr. Ayala, did they look at the different LDL, or was just the absolute number?
Yeah, the as far as I know, it was only the total cholesterol, the LDL and the HDL. But your point is very well taken. I want you to know that there is definitely data in which the particles, the size of the particles, are related to how bad, what kind of disease you're going to get.
I am so glad that you're here today to talk. This is a subject we've not never talked about before. I appreciate it. We're going to go to a break and we will be back. Everybody just
call your friends and tell them to tune in because this is going to be very informative.
And this is going to be our next article in our June issue.
Yes.
No, it's already June.
No,
we're going to July. So it'll be 4th of July issue.
Yes.
Okay, so we'll be right back with Dr. Mencia, of course, and Dr. Ivan Ayala.
And in the Lescui.
Thanks for listening to The Wonderful World of Wellness with Dr. Andy Mencia. Be sure to tune in each Saturday morning from 7 to 7:30 right here on WSBR 740 AM.